You change.
What would have
the
happened?
course of the earth, you know, space.
Nice guy.
Yeah, we're good? Okay. So let's begin. We're going to begin with a, first of all, welcome everybody for coming tonight. Thank you. But let's begin with a attendance roll call.
When I call your name, please say present. Robert Winchell, Joseph Schenker,
Present.
Michael Batch, Robert Ackerman,
Present.
Laura Ivacoli, Stuart Kessler, Matthew Fink, Wallace Carter, Eric Cohen, Kevin Manjal, Cindy Basilios, Grace Cacciola, Dario Gonzalez, Glenn Aceda, Bradley Kaufman,
Alternate present.
Nathan Reisman, I already noted her. Al Olai,
Here.
Nicholas Alexander,
Here.
Doug Isaacs, or William Hassner,
William Housen present.
Kevin Ward,
Present.
Anne Marie Gurgenti, Andrew Dahl, Allison Burke, Jeffrey Raybridge,
Present.
Lauren Casterco, Reed Caldwell,
Here.
Jonathan Berkowitz, Louis Marshall, Michael Redlener,
Present.
Dominic Bettinelli, Ethan Rendon. Who's that here? Dominic Bettinelli, Ethan Rendon, Peter Wire, Eric Blutinger, Paul Barber,
Present.
David Benelli,
Yes.
Mary Foote, Mark Cantor, Ed Jarvis, Nicholas Vicari, Joseph Bowe,
Present.
Sean Graves, Jessica Van Voorhees, Benjamin Zabar,
Here.
Matthew Harris, Robert Krupe,
Present.
Arthur Cooper,
Here.
Yedidia Langsam, Anthony Chalish,
Okay, thank you, everybody who attended. Like we said at the last meeting, we are going to be looking at attendance. And based on attendance, if people aren't coming, those positions will be vacated and open for new members. Before we go on, I just want to approve the minutes of the last meeting, the October 17th meeting. Any questions or concerns or comments about the minutes? They were sent out via email. Hearing none, I'll entertain a motion to accept them. Seconded, thank you very much. Okay. Correspondence report. There were no action items by New York State. There is a training. Maimonides will be hosting the second annual All EMS Journal Club at Francis Tavern on December 19th at 7 p.m. Francis, sorry, my bad. The discussion will be based on the clinical paper, a retrospective comparison of the King laryngeal tube and iGel supraglottic airway devices. A study for the CARES surveillance group. So that will be on, like I said, at Francis Tavern on December 19th at 7. Okay. There was an email was received from one of the paramedics, Yehuda Lowenthal, about duoneb dosing based on the public notice that was sent out, that all patients will receive a full dose of ipratropium bromide, regardless of age. So again, that was just sent in. An email from Lauren Casterco, informing that the NYU Langone has a new EMS medical director, Michelle Safferman, who did a residency at Mount Sinai Morningside and followed up with an EMS fellowship at the University of California, San Diego. And that concludes the correspondence. Any questions about that? Okay. Okay, the executive committee did not meet, although there was a discussion about the use of iGel for BLS providers as a pilot program by Jamaica and Flushing Hospital. This was sent in to the region. It was signed off. It had been discussed actually at REMSCO, but it never came to this committee for discussion. There was a large email discussion about them doing this project without clear and effective notification to the region. So there is nobody to present the project. It is a pilot project being done by the Hudson Valley region with a QA component, with all the aspects of it. It is a statewide program to look at BLS use of iGel. And Jamaica and Flushing are planning to participate in that program, submitting their QA data, which we would have access to as well. There were some concerns. I would entertain any discussion about that project now.
Process.
So from a process perspective, the region had to have been informed and made aware and a sign off on it. That was done at the REMSCO level. It's an operational decision. They're not looking for anything from us. They respectfully agreed to hold off until this meeting for their pilot because there was a large discussion and we wanted to make sure everybody was aware of what was going on. It is not, it was operational. I asked them to hold until we had this discussion. They are not doing it at this time. They did start and then they stopped because we asked them to. Yes, Art.
You mentioned that there were concerns. Were they substantive concerns or were they process?
Process.
Process.
I don't think anybody really has concerns about the use of the iGel. It's more of a process issue.
It was more
that
operational.
there wasn't a good information, and there was some discussion whether there should be some kind of advisory for paramedics to be aware in case they are
Arrive on the
they
scene.
arrive on the scene with it in place, and how do they manage it, or what do they need to do? Well, I mean, again, what's considered air, I guess it is an advanced airway, right? Yeah, they'd have to ventilate the patient and everything as normal.
We have any advisory on that, what they're supposed to look for.
But this was the discussion. Yes.
So are you making a motion that we should put out an advisory?
We can make an advisory, but we should not approve it or disagree. We can, but we're not gonna endorse it. There's not a lot of questions about it. What are they using the technology? How are they tracking it? If they're recording? Are they meeting what we want to do? I think it's fine. But to just jump in there and then put on people sign off, for the medics signing off that this is okay.
No,
No.
it's a pilot project approved by the state for BLS to do. I mean, if we don't want to use it in our region and somebody wants to make a motion to not use it in the region, that's something that we could do. But I think the bigger concern is that any provider come on scene and has an iGel in place, they should be aware of it. Rather, I think it's more of an awareness level than to say that it's not an appropriate use of a skill. But hold on 1 second, David. Ben,
Oh, no, I think.
you had your hand up, and then
I was just, the paperwork I saw about the project did say that the medic, who takes control of the patient should sign off. That the, iGel takes correctly.
okay.
That's what I want to say as well. Plus I think the paperwork even goes down to the detail of saying that the medical document in the ELS PCR that the iGel is in place, and that's problematic in multiple levels. So that's something that needs to be looked at.
Ben,
I'm not opposed to it. I think, you know, and with a mechanism, if we were opposed to it, whether that's, we have to do that through the REMSCO to oppose it. I'm not a lawyer. You know, it seems to me that there's a big medical component of this. And if there is a state pilot program and we felt that it was not appropriate for our region medically, I think it's something I think we have the right to potentially oppose. And I hear what Dario is saying about, you know, that there's not enough information to approve or deny it. I think from a process standpoint, it would be better if at some point our REMAC either, gave assent to it or opposed it. Versus just saying, well, it's a pilot program and we can't say anything one way or the other. So I'm not saying we should say they're not allowed to do it until at some point we vote, but I think at some point we should either say we're in favor of this in our region, this pilot program, or that we oppose this in our region.
I spoke.
Michael,
Thank you.
So the policy statement is from January of 2022, right? So from New York State. So, I don't think that the agency followed the recommendations in that policy. And so I do think that we should, again,
in what?
In what way?
because they didn't get approval from the region.
They did. They did get approval from the REMSCO. They did not get approval from the REMAC. So they did get approval from the region. They followed their process,
Gotcha.
but it wasn't something that we had a chance to review. Charlie, you have a question?
Standing for Marie.
Oh, Maria has a question?
You need to turn on the speaker.
But yeah, they did submit it to the region. It just didn't come to REMAC. It did go to REMSCO. Or REMSCO was aware of it and signed off on it.
Well, it's not a medical body.
Again, I think the information was an operational thing
Why are we here?
from the policy. It was sent as an operational thing.
Why am I here?
It's a good question. We all ask that question every day.
No, seriously.
Same question gets asked
I
at CMAC.
think they overstepped their bounds.
Okay.
Fair enough.
Wait, nobody else talks besides Marie.
Yeah, go ahead, Mike. Sorry.
She sounds like a man.
Marie, thank you.
Marie, you're muted.
Oh, darn. I had such a nice speech. No, I just said that we have REMAC reps on CMAC, both from fire department and from the REMAC. So this should not come as a surprise to anyone. Those reps supported, from what I remember, this application. So this has already been medically approved. I mean, this REMAC can decide they don't want to approve it. That's fine. It's a loss, I believe, for this region if we decide to come out against everything that the state does. Occasionally, it
I
would be
don't
nice.
think that's what's happening, Marie. And no one's questioning whether it was approved at CMAC. The process is that they are supposed to inform the region. That happened through REMSCO and not through REMAC. And because it's a medical process, we should have at least it should have been discussed here. So this is a process problem. I don't think anybody disagrees with the medicine of it. But Michael, go ahead.
I guess my only point is that if they followed all of the processes and this feels like something that was left out, and I agree that we should have been involved in the discussion and decisions about it. I think we should do everything we can to expedite it as much as possible so that we can move forward with it. So I don't know if that's kind of, again, get organized around what notifications need to go out to the region. But again, do what we can to expedite the process.
Yeah, I think I agree with you. I think that I asked Jamaica, just to hold off until we had this discussion. I think that, I think David made the suggestion that a advisory kind of documenting what the expectations of this process are is probably warranted. Yeah, go ahead.
Medical question. So we're talking about an iGel by an EMT.
Correct.
Is this in cardiac arrest only? Only? Yes. Okay, so I'm not sure. That's the part.
Okay. Joe? Go ahead.
No, we don't.
So the intent is that this is cardiac arrest, given that in this system, we'll often have multiple agencies respond to the same cardiac arrest. Is it the expectation that a paramedic from one agency would be signing off on a skill performed by an EMT of another?
So.
I think that is part of the process, but go
So
ahead.
when we talk about signing off, I mean, because we were just talking a little before this. I think I mean, I assume with a cardiac arrest, especially, the medics would maintain control of that patient, right? It's their patient, it's a cardiac arrest patient. And so the medics either need to decide that that iGel is functioning appropriately and they're going to continue to use it, or they're going to decide it's not functioning appropriately and they're going to remove it and either bag the person or intubate them or do whatever they're going to do. So when you say about signing off, it's like they're presented with this thing, they either need to use it or replace it. It's sort of like you have another agency who put out a tourniquet. You either need to think it's working or you need to say it's not working. I'm going to put a new tourniquet on and document it. So I don't know what the paperwork says on signing off, but like they're going to maintain custody of that patient, the ALS.
Or you.
No.
But yeah.
No, I think that might be some of the language that.
For a advisory, so the medics in the field know that they may encounter.
Go ahead.
And that they shouldn't, yeah.
There was no different than if they came to a medical clinic or surgery center where they had intubated the patient, you're gonna put your cap down with the annual verify.
Yeah,
No,
I agree.
Either you'll keep it or remove it, and it's one better than a small agency to try it, as long as the data goes to the fire department to see how it's done. I don't know if it's a personalized system to see if you can pull the data, and see the efficacy of the.
Yeah, so
Why are we collecting the data?
you're not,
You're not.
Yeah.
that was my point.
And the other issue is if the medics are not, if our medics are not trained in this technique or procedure, how are we signing off of being able to establish that that is acceptable?
Well, I mean, I think that almost all paramedics that go through paramedic training are trained in supraglottic airways. This is a supraglottic airway.
The IGL is different than what they're training.
It's a
It's a
different
different
airway, but
tool
it's-
that they don't have.
Okay.
So that's a different kind of training. Everything in the fire department is a different training.
Sure.
So they have to, when they encounter this, they need to be up to speed with how this functions and works and be comfortable with it.
Sure. Hold on, Mike, did you raise your hand? Dr. Redlener, did you raise your hand?
I don't know, I think we have an opportunity, do we have an opportunity to define what it means to certify? I mean, like, is it entitled CO2?
I don't think that there's
That's
any
not what it is.
certification. I think what the expectation is that somewhere on the BLS PCR, it's whether or not the ALS provider continued to use that device or change that device. And that's the limitation, that's what they mean by certified or whatever the language it is. Basically, was it we have the language right here. I'll let
Yeah.
Jeff read it.
So it doesn't say anything about certifying. It says if ALS intercepts, an ALS provider must confirm correct placement. Doesn't say how or what. And the next line says if there's no ALS available, the emergency department medical control NPPA physician must confirm placement. Then the last line is document in the PCR the confirmation method used. I don't think that means us documenting or the medic documenting. It means the BLS PCR. Right? They're going to document how that tube was confirmed. Right? Either ALS continued to use it or, tube placement verified by hospital.
Sure, I like that. In my opinion, when it was passed up at the state to be used as a pilot program, was that they work within their region, their own system.
Yes.
We have a different system here where we have a third party controlling 911.
I understand that, but
So it's completely, we're not synchronized together.
so you can make a motion. So when a pilot project is approved in a state that a region proposes, it can then be used by any region.
Correct.
But a region can also say, this region won't participate. That is one of your options to decide.
Well, that's what they said when it was approved.
Right,
but
so
there-
I'm just
that's what they were
reiterating
looking
that.
For other agencies that want to participate.
Right, that the region could decide that no, the region is just not going to participate. To your point about supraglottic airway, I think, yes, it's not a king tube, but it's a supraglottic airway with a single lumen, and I think paramedics can assess whether someone's being adequately ventilated through it or not. Whether they particularly use that one or a different one, I don't think that's a huge issue.
Well, it's huge in that our system is different compared to other regions, right? We have a fire department here that oversees 911. We don't have it. They don't have that system up there where their region is all together. They have one system, right?
Right, but we also have other agencies in this region that use iGels and their paramedics use iGels and So there's, the paramedic,
nine-one-one system.
okay, but the paramedic that responds to this call, it's not necessarily gonna be a 911 paramedic. It could be a volunteer paramedic. It could be a proprietary paramedic who has,
nine-one-one.
this has nothing to do with that.
Collaborative agreement with the fire department.
Yeah, but
that's an
operational issue. This is.
So if operationally you want to say that Jamaica can't do this, that's a fire department thing, and I would leave that in Glenn's hands. But from a medical perspective and regional perspective, that we're talking about regionally, if this pilot project makes sense, which I think it does, how do we let everybody in the region know about it? Nathan,
I want to make a motion about this.
go ahead.
I want to make a motion that the REMAC supports this project, but we request the agency that wants to do it should come to the REMAC to answer these questions and to propose something to put out for the rest of the region so that everyone else can know what's going on and know how to verify placement, what they're expected to do. Because we're kind of they're not here. The people who want to do it are not here to answer these questions. I think that's it.
Oh, I don't know enough about the project. And some of these.
Oh, wow.
Oh.
But
When you bring up the medical records protocol, it's starting to bring people kind of get out, right?
Yeah.
The protocol component is the medical component.
I think.
wait, hold on one second, guys, before we go any further. Can you just state that motion again so that somebody can second it if we want to do that?
Motion that the REMAC supports this project, but we want whoever wants to do this project to come to the REMAC with a plan.
Does that include Jamaica and Flushing?
Whoever wants to do it.
I mean, they already did come to the region and it was signed off on. That's the only problem.
To the REMAC. I don't think
Okay.
it should be a 911 agreement. I think it should be a non-911 for the.
Okay, but that's not what we do at REMAC.
That's not
REMAC
REMAC.
is not a 911 versus not
That's a fire
911.
department
If the
contractual.
fire department operationally wants to say that
But the
an agent,
region's in charge of 911 and non-911. So
so
therefore, we can make a statement like that.
again, but the region, so operationally, if the fire department wants to say that an agency in their system cannot use this, that is an operational thing for the New York City Fire Department. From a regional perspective, we are talking about the overall process. Right now, the motion on the table is that we approve it with the stipulation that it gets presented at the REMAC and an advisory is sent out to the region. Does that sound appropriate? Okay, so that's seconded. So that's the motion on the table right now, which we can discuss. And if we agree to approve it, we might want to give Jamaica a break because they did actually come to us. But we might want to say that they need to wait till the advisory is out before they go ahead and start operating. Yes,
I
Darren.
would have to oppose this motion. I think we have it backwards. I think it's a good, only good project, a good thing to do, except we never got any information on it and we're approving it. I would like the information to come forward with a QA plan,
so
slow down. With a QA project and presents it, and I think it would pass very easily.
right, but that's already been done on a pilot
No, that
level
was
for the state.
REMSCO and
No.
the state, we
The-
don't
the-
want
the-
us to sign on to it without knowing.
Right, but we don't want them to do a second QA project over the one that they already have to do. I
We
don't think
don't even
that's
know what
fair
the
to the
QA
region.
project is.
Just asking, what is?
Okay.
Let's-
All right,
The main difference is that in smaller regions upstate, it's probably one agency doing everything. And that's easy. Here, there's just an added component of how do all the other agencies deal with this project. That's why it's more complicated. I don't think anyone.
okay.
And that's why I think,
Have to-
What's the question?
and that's why I think it should be a non-911 type of,
Give me 2 seconds. So I'm gonna clarify this so that Michelle can write it down. The motion that was made was to approve this regional project with, hold on, let me finish, with the stipulation, and tell me if I'm wrong, because if I'm wrong, then I will correct
I
it.
didn't mean to prove, I said that we support this project, but
Right.
we can't support it until we get the.
Okay, so that is to support this project, not approve, support this project with the stipulation that the agency present it at the REMAC and an advisory is sent out to the region to describe the process, the project. Is that fair?
Yeah.
Okay, I just want to make sure that I'm getting it right.
You're saying that we want the presentation before the advisory, before it's.
Yeah, we want to, because we got to figure out how it's going to work with like 10 different agencies responding to these.
So are you looking for a presentation from the agency that wants to use it, or are you looking for a presentation from the state approved project of what's being done
No, I think the
Statewide.
agency has to tell us how it's gonna work in New York City with multiple agencies. You know, I think
It's multiple agencies in other regions too, just so you know.
It's probably appropriate is that this protocol was probably not written with New York City in mind. That's what.
It's not. We have a different region. That's what got approved upstate. It's one region with several agencies within their region that agreed to do this. We have a third party. We're very different and unique in that we have a 911 system that's different. And it can't be overseen as a QA project the same way.
Charlie, Marie,
I'm sorry, this is, hold on, let me just make sure. This is clearly a fire department issue with with one of its contracted units. And this should not be, it's not REMAC's place to stop someone from participating in something like this. I think that the fire department should be dealing with their contracted agencies one-on-one. That's just my opinion.
all right, now, so let's, hold on, guys. We're getting a lot of different things going on here. First of all, Ben,
Yeah, I mean, speaking for myself, I'm not speaking for the fire department. I know Brad, there are other, I think the REMAC, I understand this was all done with good intentions, but I think what the motion that we're trying is that the agency that wants to do this should present to the REMAC, should get approval from the REMAC, then an advisory should go out to notify people of it. This isn't a 911 issue. This is to make sure that this project is, makes sense for New York City. And I'm saying that as a REMAC representative, not as a fire department.
okay,
I second it.
Paul,
Exactly what Ben's.
what's that?
I second it.
How often are you gonna say that? Wanted to grab like. Think we all,
Support,
like,
this
the weight of my
REMAC
statement.
should
to say,
support
I
this
fully agree.
project with the stipulation agency present to
So
the
is
REMAC
so I'm clear, is the motion then that an agency that wants to participate in this
to
project will come
describe the project.
to present their plan to the REMAC? And then if approved by the REMAC will issue an advisory explaining.
But
Is that what you're
can I-
saying?
can I make-
I'm just confused, yeah.
I think what we're saying is we're just gonna support it. And, right? And,
So-
but we need the information to say we support
Hold
it.
on.
Other than that, you can leave us out of it and we're not supporting it.
So let me, okay, again, before, guys, give me a second. I'm gonna read the motion so that we're all on the same page as to what it is, okay? The motion is to support this project with the stipulation that the agency present to the REMAC and an advisory be written and issued. That's the motion on the table. Did I get that right?
Well, yes. I
You
mean,
can amend your motion.
No, but.
Well,
by
no,
support,
you
I don't
can't-
mean approve. I mean that, I just meant that everyone here, I think, supports this project. Without.
Right.
You know.
You didn't read approved.
I said, REMAC will support this project with the stipulation that the agency present to the REMAC and an advisory be issued.
Present and get approval from the REMAC. How's that?
So again, I don't, we can do a couple things here. This project is a pilot project approved from the state. We can either decide to not do it in our region, say that this region does not approve this pilot project. Or we can say that we do approve it, and then we can have the regions kind of go over it and make sure that an advisory has gone out so that any agency who encounters one of these IGLs knows what to do. I don't think that we can say, if somebody presents it, say, we're not gonna let you do it. We can either blanketly say we're not gonna allow it for the region.
But how can we make that decision if no one told us what they're actually doing?
But again, that's what I'm saying. This is approved at the state. You can send out, you can see what their QA responsibilities are, what the protocol is, what the documentation responsibilities are. If you have specific questions for an agency, I think that agency, I agree, should come here and answer those specific questions, what their expectations are. But I don't think that we're not asking them to come here to say, yes, you can do it, or no, you can't. We're asking them to come here to tell us about it so that we know what's going on. First Art and then Nick.
Listen to the discussion, you know. There's what you said at the outset, but I think the veterans hours is 100% correct. Okay. that without our having had the opportunity to review what's involved, it's very difficult for us to, to make a statement about this project. That having been said, is this the hill we want to die on? Do we want to fall on our sword over this? Clearly, on some level, somewhere, somehow, and I'm not getting into the blame game here, somebody forgot to bring it to REMAC. Or didn't bring it to REMAC. It should have been brought to REMAC. It wasn't. Okay. But the fact of the matter is now that we have this state approved project, and as we pointed out, we had representatives there, the motion was approved by the state, and I don't want to see us, if you will, end up in a fight with somebody over a project that, we all think is a worthy project. I think on balance, I think that supporting this motion is probably the best course we can take. Just get the information and get the advisory out and let it go and make sure that the process is cleaned up. One final point. This is being called a pilot project. Now, to the best of my knowledge and belief, unless the law has changed, I don't believe it has. Under state law, there's no such thing as a pilot project. There's a demonstration project. That's the term of art. Okay.
Yeah.
And as I recall,
It's approved as a demonstration.
under Article 30, okay, demonstration projects, are approved by the REMSCO, not by the REMAC, even though traditionally and customarily REMAC has the responsibility. It clearly has the responsibility, but nowhere in the law does it have the authority to approve demonstration. So given the fact that the state has approved it, that our REMSCO in this region, had already approved it, we are a subcommittee of the REMSCO under the state's, legal, interpretation of the statute. I think that making a stand on this issue when we all think the project is a worthy project in the first place is probably not the right direction to take. While I totally agree with Dr. Gonzalez, okay, on this, the information ought to have come here. Okay, it needs to come here, etc. I don't think we should stand in the way of this project going forward.
You're 100% correct, although they call it a pilot project on the state's website, but you're right, it's a demonstration project.
Dr. Van Vries.
I just want to say, I'm not sure an eye gel is wildly experimental medicine, and I would agree that, it helps you back on patient, ABCs. Maybe this is, again, our style.
Well, Mike first, and you can do that. Mike.
I think I have an alternative suggestion because I do think that it's maybe on our responsibility as a region, REMSCO in particular, to consult REMAC on things like this. I think that perhaps instead of waiting for another 2 months and presenting the project in January, maybe it'll get postponed to February. I do think that it would be fair to bring it to the quality committee to make sure that the quality plan is fine, that there's a representative group of people who can sit and say, we can give this, we can give, again, we understand what the quality cases and that's acceptable to a joint committee of REMAC and REMSCO. And then we can write up a regional advisory. And I just think that if we put them through the hoop, make them jump through so many hoops, I think that it's just going to be, next year by June that they're going to be doing it. So I do think that it's reasonable in the future to ask REMSCO to ask REMAC around these medically based projects. But I think that there's a way to kind of thread the needle that we would all feel comfortable with.
Okay. Cool question.
Second.
Okay, so let's all vote to call it. And then we have to vote on, so we're voting to
End debate.
end the debate.
So I guess I'm not a good.
This would just be by hands because it's not the protocol itself. All in favor of calling the question, please raise your hand. All in favor of continuing the debate, please raise your hand. When somebody calls, okay, when somebody calls the question, that means that immediately you have to go to a vote. That's what it means. So just so you understand. So we can, it's been seconded. So now we vote on that question. If that vote is a yay vote, we then immediately move towards the vote on the motion. If it's a nay vote, then we can continue the discussion. but that's where we're up to, parliamentary, who's he, what's it? Okay, so all in favor, all in question, please raise your hand. This means that we're gonna go immediately to vote on the process. Okay, all opposed? 6. All right, so we are calling the question. We are gonna vote on this motion.
Can you just explain? If the motion is approved, I'm just asking, if the motion is approved, is this project in effect immediately?
According to this, no.
Okay.
All right, according to this, no, they technically should have to come here. Now, the fact is, they did go to REMSCO, they did what they were supposed to do. We probably have to figure out a way to make it a little easier for them, but that's the answer. All right,
I can't make a motion to make an amendment, can I?
No.
so you can vote against the motion.
Okay, well, let's vote again.
Okay. Guys, so this is the motion that we are voting on. Hello?
Should have just done it then.
This is the motion that we are voting on. To support this project with the stipulation that the agency present to the REMAC and an advisory be issued. That is the motion that is on the table. Okay, we're gonna take a roll call vote for that motion.
When I call your name, please say in favor, oppose, or abstain. Glenn Aceda,
Say,
Bradley Kaufman,
You're Bradley Kaufman.
alternate, Sophie,
Make your own. In favor.
Dario Gonzalez, Nathan Reisman, Pamela Lai,
In favor.
Nicholas Alexander,
Against.
Doug Isaacs, or William Hassner,
In favor.
Jeffrey Raybridge,
Opposed.
Reed Caldwell,
In favor.
Louis Marshall, Michael Redlener,
Opposed.
Joseph Bowe,
In favor.
Arthur Cooper,
In favor.
Robert Winchell, Ed Jarvis, Nicholas Vicari, Mark Cantor, Robert Krupe,
In favor.
Laura Ivacoli, Matthew Fink, or Wallace Carter, Kevin Manjal,
In favor.
Cindy Vasilios, Jessica Van Voorhees, Paul Barber,
In favor.
David Benelli.
Favor.
He's not here, correct? Peter Lyer, Eric Blutinger,
You need 16 in favor for the motion to pass. So it does not, the motion does not pass. Okay, so we're now back, yeah, Michael, go ahead.
I'd like to make a motion.
Go ahead.
I'd like to make a motion to review the plan for the implementation of this project, the IGEL project at the Quality Committee for review of details and issue an advisory to the region in order to start the project.
Your second,
I'll second.
okay. Your question?
No, I want to discuss.
Oh,
Second.
discuss, go ahead.
So I just want to clarify, so
Yeah,
the
please.
QA, this project was approved by the REMSCO, right? And there is a QA plan as part of that, and all this stuff is both on the state and the Hudson Valley Regional website. Where you can review the documentation, the QA requirements and the plan, and it's all there and present already. I'm not sure if you're saying that our region would then have our own QA plan for this, or we're gonna collect our own data, or I'm just a little confused about your motion.
Hold on.
party that,
Yeah.
we have a fire department that needs to sign off as part of that QA.
No, it doesn't. No, it doesn't, not at all.
Well.
That's not true.
Scene, and we have
Nicholas, it's
somebody
not
that
true.
has.
That's
that-
not true.
Nick, it's not true. So again,
How?
it's not a fire department QA issue at all.
But our medics
regional
that go
QA.
on the scene of a call that has an EMT that has
So-
placed an IGEL now has to verify and make sure that the IGEL is appropriate.
So you can make an operational guideline that as soon as they come on the scene, they pull it and do whatever they want. That you can do, but you can't, the fire department is not involved in the QA for the region. Go ahead.
So you want me to clarify, like?
Yeah.
I'm asking you to clarify.
So my clarification, like, I think, again, I think that we made, like, I think in general, that the quality committee should be involved with this discussion and decision, and it wasn't. So I just am I would like to rectify kind of that aspect of this
So you're
process.
saying the QA committee wants to review the project and then make a recommendation to the REMAC, is that what you're saying?
Perfect. Yeah, I would, again, I think that.
One second. I don't even know if we need a motion for
Yeah, we
that,
don't.
but if
No,
that's
I'm
the
just-
case, then. we
Yes,
can
that's,
just
but
let
that's
them
what
do
I'm,
that.
that's what I'm.
That's
sorry,
all I'm
thank
asking.
you. Assessing the project quality, the quality.
Okay, so Paul and then Ben, and then we're gonna make some decisions here. Oh, go ahead. I'm sorry. Paul, Paul, go
No, I
ahead.
just wanted to make sure he saw you, that's.
I'm sorry, go ahead.
Just as part of discussion that the quality committee of the REMAC review the quality program set forth by the state in the demonstration program, and if so approved by our said standing committee, that the quality program that the state has already approved be adopted as part of this region with the approval of the sitting quality committee here at the REMAC.
Thank you. Glenn.
So first, I apologize, you're so late to traffic. Probably would have discussed. You know, I would first say that, so far as those the microphone. You know,
Step up to the mic.
it's not opposed to this project. I want to go on record saying that because I'm always thrown under the bus and say that the fire department's against. We're not against it, right? But what was very concerning to me is when one of my deputy medical directors brought this to say, hey, did you know that 10 days now they're potentially doing this project in New York City? I'm like, what are you talking about? I heard about this at the state level, right? We all did, just like the 12 EKG that BLS can do and such, which Marie.
She's on the.
On the phone.
On the phone.
Oh, we
Yeah,
Marie
she's
said
virtual.
that in REMSCO, they had declined it for the region, right? So it's not just because it's an approved demonstration project or whatever that we approved. And so I was surprised to find out 10 days into the project. This is the first word that I was hearing about. So I thought I must have missed the REMAC meeting. And I did miss one on April 18th, I think it was last week because of the building class. I'm like, must have missed it. And I thought, shame on my guys for not telling me this, but it wasn't discussed, right? So something like this, especially when, yeah, there's an established protocol and such, but our legal is gonna have a difficult time with having our medics on the tubes there. And you're right, we could have a protocol that says we can pull it, I guess what you're saying. But it doesn't make sense either, right? I don't think that's the best way. But there was no discussion as to how we were going to do it. And that's why when I heard of it, I just sent that email to you to say, I must have missed the meeting. I just wanted to know how this was. And it turned out that that wasn't the case. It was signed off on at REMSCO. And according to the paperwork from the state, it does have to get signed off by REMSCO and then by the Hudson, is it Hudson Valley?
Yes.
Or whoever?
Yep.
Which is odd, but okay. Again, there's certain things that, yeah, we could be different from everyone because our legal is not going to say our medics are going to be able to sign off on an IJA. Luckily, we're going to IJA finally after 15 years or so, right? From the comments, very embarrassing to me, but finally we're going to the IJA. So we're going to be trained in the IJA. But if you're a voluntary that's doing the King Airway, is it right for somebody who just knows King Airway to say, I'm going to sign off on your IJA? That's up to the individual medical director, I guess, and it's probably not a difficult thing, but these are the things that need to be worked out. And one of my docs said, well, why would BLS be calling telemetry? Because there's a telemetry component as well. And for us, it's not BLS calling telemetry about the tube, but it's really the medics getting on scene going, hey doc, BLS put in this iGel, we do King Airways. What are we supposed to do with it? So we have to have some kind of discussion as opposed to finding out 10 days into this thing that they're potentially doing this iGel. That's why I brought it to everyone's attention. And so I just bring it up again here. Yeah, QA is going to be through the region. I get that, right? It's not really a fire department thing. And you're saying we could have a different thing. I don't think we should have a different thing. So they take the tube out in some systems, some agencies, but others not. That doesn't make sense.
Right. So I agree with you completely. And I'd like to say for the record, I take responsibility for not having good notification. There was an email sent out about a month before this project went live that had the hospitals listed on it. Marie was not on it. I think I was on it from senior care. Glenn was not on it. I think David was on it. It was not appropriately sent out, and the REMSCO approved it without us really discussing it. There's no question that we should have discussed it. There's no question that we should put out an advisory that makes it very clear to the region that this is going on. I totally agree with everybody about that. That said, I don't mean we can decide who is going to do that advisory. I don't know that reviewing the QA project plan to approve or disapprove it is really what Michael's intention was. I think it's more to say, what we want people in the region to know about this. Does that make more sense? I mean, I think that's really what we're trying to do.
But, yeah.
And listen, we can say no. I don't think that's the right thing to do. We could say yes with the stipulations that you're suggesting. I think we should have an advisory that goes out that makes it very clear what is the expectation of this sign off or whatever it is, as well as to know. I mean, I think most people get trained on iGels in their paramedic program, but to at least know that it's out there and it's going to be happening.
I think the most important thing is that we have a little bit of time to process what the system will do and to inform the people that will be on the, on the receiving end of these cases. And again, as you had appropriately mentioned, it is on the state website for people to review and to look at, and we can all do that. So again, I think the purpose is to give us some time to adjust. But again, I think that the problem with waiting to hear a presentation and the specifics of this case it's not necessary, right? And so I don't think delaying 2 to 3 months, but I maybe setting a date for it to go live and to work on those details offline.
Why don't we? I mean, again, there is a motion on the table.
Yeah.
I would like to table that motion to the QA committee to review what's on the state website, what is the QA plan, and to develop that advisory, which will be sent out by the executive committee before the next meeting, if it is, and again, if that's something that everybody can agree to, I think that we can do that to therefore, because I think Jamaica did do their part in sending out the right paperwork. I do think that we should have had a discussion about it here before it went live. So I think that would be the appropriate thing to send it to QA to review what the project is, as well as QA requirements, and develop an advisory that can be then sent out, hopefully before the next REMAC meeting, which is in January. Okay.
I second it.
It's a good plan.
So again, we're going to table this, so there's no vote on it. It just gets sent to QA for them to discuss it. We're not going to have that vote on that.
There's a lot of details on the state website.
Go ahead.
Showing me.
Just want to ask that this be done in the most expeditious manner possible.
Correct. I agree.
Nothing's going to happen over Thanksgiving weekend, but if those of us who are members, chairs of QA committees, could really get cracking on this thing, so that maybe the QA committee could meet very early next week, and executive committee very shortly thereafter.
We're meeting. Our next meeting is planned for December 6th. That's pretty close. It will give us time to write an advisory, review it there, and send it to the.
Just want to be sure that we don't hold
But again,
this up unnecessarily.
I agree with you, Art. And then, but again, I think that for the region to just kind of help us to kind of. What are the other things that go into that to make it feasible to go live? But we'll do our part in the quality committee to get the advisory written and met to discuss.
Thank you. Okay, moving on to subcommittee reports, because we haven't started that yet. CNC, Dr. Barbara.
Yeah.
Yes.
CNC had a uneventful meeting on November 16th. 3 topics to really be aware of here. Extensions are being aligned with extensions are being standardized with the state, and with regards to your status for an extension, we're going to be basically streamlining that in the coming months and having an application for form. In the past, it's been a piecemeal letter to Kevin Ward with a little bit about the executive approval. So we're going to be standardizing people who are looking for extensions for whatever reason, whether medical, family need, military services, amongst others. But we'll present that when it's more formalized. There will be, in the absence of a protocol update, there will be some yearly updates posted on the LMS in conjunction with the Training and Ed Committee. It's going to be a recycling of some old topics, but topics that are persisting issues in the region, just move towards a clinical annual mandatory training in the absence of a true protocol update. On the physician end, medical control credentialing is going to be, it's close to being finalized for migration to the LMS. Joe, in the light of the recent discussion, I think we'll hold off on demonstration here today. But Joe Ranieri's been working tirelessly to put the medical control credentialing on the LMS, not the content, not the academic piece, which we're all experts to teach, the various medical control training faculty in the area. Many of you sitting here, you're basically going to be, I'm going to get you guys together and teach you what the work done that way. The forms, the databases, and the click buttons are all gone. The students will be basically made to make a profile on an LMS. You will be made into an instructor on the LMS, and it's going to work very similar to, if anyone's an AHA instructor, if you work like that, it's going to be very similar to that. Next meeting is January 5th, 2024. The only other topic I want to bring up, since you talk about the state so much, is there is a state credentialing committee, subcommittee, working group thing. It put forth by some of the topics that have been brought to the state about the ability of a region to credential paramedic or de-credential paramedic. I was voluntold to chair this group. I encourage all of you to attend. Mike McAvoy is one of the major players with it. It's on Boardable, which is the state collaboration.
The meeting was set though. What's the date for that?
Gonna get to that. The meeting is November 27th, Monday at 2 p.m. If you want to invite, let me know. If you want to participate, we encourage from the credentialing committee locally that Dr. Reisman participate as well. And some of the other, we had some other people we added. Yes, sorry.
I just, this credentialing committee is really super important.
State.
Yeah.
I hope not to screw it.
Well, you won't screw it. I just wanted to make everyone aware that they did ask for members to serve on this committee rather broad. And to the extent that any of us here want to serve on this committee, certainly make our feelings known. The more folks we have from New York City, the better off we are. Because I think it's pretty clear that there are certain folks within our state who don't believe that, we or any other region should have the ability to credential anyone. Even though the plain intent of Article 30, when it was initially passed into law, was that would happen and be maintained. But the folks that are against it are now saying, well, that was never what was intended, when that is clearly not true. We're going to need to have our voices heard if we really want to, keep what we have.
I can't agree with you more. I mean, we have a seat at the table. We could use a few more seats at the table. And, my goal is going to be here at this group. Subcommittee was not to remove people from the ability to work or the ability to provide care, but more to uphold standards for the community and the patients we serve, and to demonstrate, EMS in itself as a healthcare specialty. We need to speak to the hard work that our providers do and the accolades they deserve themselves in this field. Right. November 27th. If you want to be added, I have to you may have to send a CV to the state, but via the internet streaming webs.
Thank you. All right. Is that it?
That's it.
All
Kevin,
right.
anything? Excellent.
All right. Medical standards, Dr. Benelli.
Okay, so medical standards met 2 weeks ago via Zoom. There's only one action item that's being brought for discussion. And for voting, a second motion from medical standards. I'll let Dr. Lai present that protocol, and then we can have a discussion.
So the one protocol that's coming forward from medical standards is the head, neck, and
spine injuries protocol that was discussed a couple of weeks ago. As you can see for the changes that we have like up on the screen, the main difference and the main changes that we're bringing forward is that now spinal motion restrictions and also the use of this term, even though it has been currently taught in the CFR level for quite some time, but to move the actual action for spinal motion restriction, to move that to the CFR section. I do just have a note here that there also, as part of this language change, that this will also be reflected in the GOP other protocols as well as the appendix. I just did not want to necessarily bring those forward as separate documents for this committee to review, as it's just an inconsequential change if this gets passed. So you can see that we have the changes here for the spinal motion restriction criteria. For those patients who have a mechanism of injury suspected for spinal injury, as well as having one of the following criteria that you can read on here. The other thing that was added on here is just a clarification for the key points section. In particular, it's going to be for patients who have isolated penetrating trauma. That is like for those patients that in particular to the back, chest, abdomen, or pelvis, that these patients should not have a cervical collar be applied to these patients. This is again in incongruence with the American College of Surgeons as well as the NAMSP. This language has also been, this protocol has actually been reviewed also by the RTAC as well, and they are in support of the changes that were brought forth here.
Okay, so really this protocol is just to bring us up to date with the current guidelines, both by ACS and NAMSP. As Dr. Lai said, supported by RTAC as well. There's no earth-shattering changes over here, just bringing us up to date. I'm not sure, by the way, that we even need to bring this to CMAC for approval, because it's really just moving to the standards that already exist, and a lot of wording shifting from one section to the other more than anything else. Any discussions?
Art?
You know, it is very unusual for a penetrating injury to the neck to cause spinal instability. There's no question about that. If there are rare instances where that does happen, you know, the general rule, certainly powers should not be applied in this situation. But, you know, and I'm not in a position, obviously, you know, to oppose the palliative surgery, even though I'm a former member of the Committee on Trauma, and AMSP or the state on this, but, or our own regional, trauma advisory committee. But once again, we all do know that there are very rare circumstances where, we're applying a collar, if there's a devastating gunshot to the posterior aspect of the neck, could result in significant spinal instability. And I would hope that, there's enough leeway here that in a situation like that, our providers would have enough common sense to be able to put the power on.
And I think also, just to your point, Art, that it just specified that patients with isolated penetrating trauma to the back, chest, abdomen, or pelvis should not have a seat collar applied. So then for those instances, just as you said, if they have a devastating penetrating injury to the neck, then that would not be part of this key point here.
I think this is a nice sort of middle of the road, because the ACS statement basically says penetrating trauma should not have spinal motion restriction, period. Which should be a fairly large change. And I think there's some people who, like you said, don't feel comfortable with that, with penetrating trauma to the neck. So for now, for the foreseeable future, penetrating trauma to the neck, would still get a seat collar if you're not able to clear the spine with those criteria. But this will help clarify, someone who's shot in the chest, who's unconscious from blood loss, and they really don't have much of a mechanism for a C-spine injury. And if they did, it's probably not going to, the collar is not going to help. No, it's clear that that patient should no longer get a seat collar because they're shot in the chest. So this is an improvement.
Okay. Any other questions or comments? Hearing none, we will vote.
When I call your name, please say in favor, oppose, or abstain. Glenn Aceda,
In favor.
Bradley Kaufman,
In favor.
Dario Gonzalez,
Fred's
Nathan
voice.
Reisman, Ally,
In favor.
Nicholas Alexander,
In favor.
William Hausner,
In favor.
Jeffrey Raybridge,
In favor.
Reed Caldwell,
In favor.
Louis Marshall, Michael Redlener,
In favor.
Joseph Schenker, Joseph Bowe,
In favor.
Arthur Cooper, Robert Winchell, Ed Jarvis, Nicholas Becari, Mark Cantor, Robert Krupe,
In favor.
Laura Ivacoli, Matthew Fink, Kevin Majel,
In favor.
Cindy Basilios, Matthew Harris, Jessica Van Voorhees,
In favor.
Benjamin Zabor,
In favor.
Paul Barber, David Benelli,
Yes.
Peter Wire, Eric Blutinger.
Thank you.
Motion carries.
The motion passes.
Thank you.
Yes.
That
Just
includes,
as a slightly humorous anecdote, prior to coming to this meeting, cared for a young man with a stab wound to his back. Just needle to his left scapula. And of course, he came in with a C-collar in place, so.
Not anymore.
All right, we're gonna fix that problem.
We will see.
So go, is this,
Dr.
is this going to the
Benelli.
state or is this now?
I don't think that this is in line with trauma guidelines, and I don't think
It's
it's
language change, you haven't substantively changed the medicine, then usually not.
correct.
Do you also want this to be a part of the 2024 protocols then?
I think it should be.
I support it, yes.
David, anything else?
Okay,
We haven't decided yet. We haven't decided yet.
Okay. We need to train them.
No, I know. We have to figure out when that's gonna be, but we haven't figured that out yet. But the protocols are going to CMAC in a week and a half, so let's see what happens then. and we'll go from there.
probably once we get those protocols approved, we can set a date,
Correct.
right?
Anything
Okay.
else?
That concludes the medical standards, the action items of the medical standards report. Next meeting is on January 9th at 3 p.m. via Zoom. Michelle will send out reminders with the Zoom link. Thank you very much.
Thank you. Okay, next, Dr. Redlener, the QA/QI committee.
Sure, I was absent for the last QI committee, so I'm gonna defer to either you or Joe. Support
Busy
it.
reviewing the IGEL project.
The committee met earlier this month. It was a rather quick committee. This was the updates on the various projects that we're working on. On first watch, we've been working with them to get the updated logins to the new users. So if anybody has had issues with getting their credentials, please reach out to me and I will follow the first watch to make sure those are getting issued promptly. We do have one paramedic restriction case that is on the table. We're currently working to schedule an interview with that paramedic, review their case and take appropriate action from there. We currently have one court sponsor upgrade application that the committee is currently reviewing. They meet with the state, with the State Department of Health, one of the members from their education department, just to get clarification on exactly what kind of recommendation they want for the committee. That would provide, that will be presented at the next QA committee. We're still collecting data, still looking, developing debt, developing reports to present to the committee on the various QA projects that we're working on pain management, medications, and stairway. The next time the QA committee will be meeting will be on December 6th.
Just one thing I would just add, the First Watch project, the project to do AHA measures around stroke and STEMI has been an ongoing project for many years, got disrupted a little bit by COVID, but we're in the final stretch. And we really want to, it's a tool that's going to be usable for the region. And so as soon as we get these logins, we'll be, that will open up the dashboard for all of the users in that agency group that has this First Watch tool. And again, the other agencies within the 911 system, we said that aren't a part of this project will have to give us data related to the same items. Again, we're in the final stretch and we hope to have this tool ready, and then hopefully in the new year, we'll propose some projects for 2024 to work on some improvement items.
Okay, Morty Lax called to tell me that there was no training and education updates. So next, that brings us to the interfacility transport tag, Dr. Berkeley.
Yep, a couple of things. So I've been trying to kind of get this in a direction I think that'll be productive and meaningful. As I've become fairly convinced from my discussions with people in the state level that, we don't have the authority to truly regulate this. So we have to find a way to make it meaningful for our providers. So we do have a lot of content that folks have given. One of the things I'd like to do, and I wanted to just ask people in the room to see if they agree that it would be helpful, would be to survey our providers to find out where our providers perform in their facility, where they see the problems are, so that we can actually try to target some solutions. Because one of the things that a few people told me was that this is kind of a solution looking for a problem. So I think we should be looking for the problem so we can come up with some solutions. And right now we have great content, but it's coming from people who are probably removed from the actual work that we're trying to help. So it's kind of more of an open discussion. But since I have your opinion, anyone has any thoughts on that, I'd love to hear your thoughts. You can just email me. We don't have to take up time. We had a lot of discussion already, so we don't need the discussion. You can just email me, but anyone who has an opinion on that, I'd love to hear.
Thank you. Anything for Dr. Berkeley? Any more discussion on interfacility? Okay. Okay, that moves us to the regional council update. There was a regional council meeting. They had a public hearing for a certificate of need, I believe.
Expansion of operation.
Expansion of operation. That was held here, and we're waiting for the hearing report, and I guess it'll be discussed at the next REMAC or REMSCO meeting. CMAC did not meet since our last meeting. The meeting will be first week of December.
December 6th, yeah.
Correct. Okay, that brings us to unfinished business. The only unfinished business that we have at this point that I can think of is the slate of officers. So there were no communications with the region on any new nominations or any of the REMAC positions. So at this point, the slate is set. And we're going to vote on it tonight, unless there's any questions, discussions, or comments. So we're going to vote on that, and then we will appoint the officers to the medical standards, and we're going to give the chairs to those committees, which will remain the same. Probably. Any questions on that? Anybody have any comments? Okay, so hearing none, then we will vote for membership. So the REMAC committee recommends the following seats for reappointment beginning July 1st. It's actually backdated to July 1st, 2023, because we haven't had a vote in a while. Joseph Schenker as the chairperson, Bradley Kaufman the first vice chair, and Jeffrey Rabbit as the second vice chair. These terms are for 2 years and they will end in June of 2025. It's not a motion per se, it's just a vote. It doesn't even need to be all the
No.
All right. We're gonna make Jeff first.
No.
You wanted
No. We're elevating.
Okay, so we can vote. This actually does not need to be a roll call. This can just be a by hand vote because it doesn't affect our protocols. All in favor of the current slate, please raise your hands. Anybody opposed? Any abstentions? Thank you. So then I thank you all for continuing your faith in us, and going forward, we are going to, again, the chairs of the various committees will remain in place. Dr. Benelli will remain the chair of medical standards. Dr. Barbara will be the vice chair of medical standards and the chair of the ECNC committee, and Dr. Lai will be the chair of the protocol committee. Dr. Redlener, I think, is remaining as the chair of the 2A committee for right now. And I think that's it in terms of the various committees. Any new business? Yes.
Yeah, real quick, I just wanted to share something.
Thank you very much. That was quick enough.
I'll be super quick. There was a paper that came out about, I think I shared it with a few of you, that came out about a month ago. Looking at outcomes on stroke diversion cases, with a post analysis on a RCT that was done in, I believe, the Iberian Peninsula. And they found actually evidence of harm. So there's a couple of papers in the past year that show that I'm gonna ask maybe we can distribute folks to look at.
Okay.
I think it is, there's definitely a little bit different than kind of what I would have expected. In those studies, and I think it raises the question of what we should be doing in stroke systems of care. I've long been an advocate of stroke systems of care, but I mean, these are randomized trials that are either showing no benefit, or in the case of ICHs, actually that longer transports are harming patients. So I do think it's worthwhile reading, and I'd like folks to folks that are interested in this topic, to look at maybe that standard. Have to start at some point in time.
Great, thank you. David, and then
I'll let Michael talk.
Michael.
No, I think again, the Stroke Systems of Care Committee has not met in some time. We've been, going with our stroke systems of care plan and process and triage plan. I think it's really important, Jonathan, what you're bringing up, just to make sure that we are not doing something that's harming patients. I think in that spirit, Dr. Benelli and the fire department will present some of the new data around what we're doing in New York City in the system. And then again, I think it's worth reviewing those articles. Again, just in my view, the system is very different, right? And the environment is very different. So, but definitely worth thinking about and talking through.
David?
Yeah, I'd like to add that, again, the devil goes in the details. And, the New York City stroke system of care is very, very different than what's going on, what was described in the Iberian Peninsula. Now, with the caveat that I have not read the full articles in detail. One of them, I mean, it's a non-urban setting. One of them did not have power, and one of them specifically focused on ICH. So it's very hard to adapt, that data to New York City. I can tell you, based on our data, that the difference in our transfer times are few minutes, minuscule. So I'm not that concerned, and I think that if we do bring a patient with an ICH to a higher level of care that can deal with them, I'm not sure that we're causing them harm. But we will present some, our data next week.
Yeah, I just wanted to ask that somehow we get these articles to Dr. Doynow, the chair of the CMAC, in a timely enough manner that he can get this on the agenda for the upcoming meetings. CMAC is actually meeting on Wednesday, December 6th. May not be, he may feel there's not enough time to share this with the members of CMAC, but this is an important issue. More, as you pointed out, David, it's probably more for the state with much longer transport times than it is for us. But I think for sure Dr. Doynow should be made aware of this. So at least he has the option of getting it on the agenda for this upcoming meeting.
Good point.
Anything else? Any other new business? Okay, hearing none, I will entertain a motion to adjourn.
Second.
Okay, happy Thanksgiving, everybody, and have a happy holiday season. We'll not be meeting again until January.
Paper just say, hey,